Dr. Choll Kim here. I'm at the North American Spine Society, and the North American Spine Society has this award through Spineline called Spineline 20 Under 40. That's for handsome young pain specialists that are 40 years or younger, and it's the top 20 specialists. So I have Dr. Vivek Babaria, winner of Spineline 20 Under 40. He's a pain specialist in Newport Beach, California, very close to me. And we're gonna talk about something that nags at me. Why do we have such trouble taking care of our low back pain patients? Because that is our most challenging group of patients.
It's a pain in our back too. The reason it's so challenging for us is that there's so much pathology in such small space. If we look at a structure or a house, there's scaffolding, there's walls, there's infrastructure, there's support systems and beams. And similarly in our spine or low back, there's, again, from outside to in, so many different layers. And then once you actually get down to the nitty gritty, just at the vertebral body or the bone and the joint level, again, in millimeters of space, there's so much different things that can go wrong.
So you can get low back pain from muscles, from tendons, from ligaments, from the disc, from the nerves, and the facet joints, right?
Yes, sir.
So the spine is interesting because it has 5 joints all stacked together, all in one small space. And then each joint has the disc in the front and 2 little often overlooked and ignored joints called the facet joints. And they're little, but they're like little knee joints.
Yes.
And they can cause pain, right? And when a patient has that problem, what do they look like? Like if I was a patient with facet pain, what would I experience most likely?
People who come in with facet pain usually are only complaining of back pain. And this brings up an important part of when you come to the visit, people don't like filling out the pain diary, but separating back pain from leg pain is so important to us because it really lets us give us a pathway, but then also lets us get approval to do your procedures. And a scenario that I can share is that if there is a component of leg pain, and we document that, 8 out of 10 insurance companies will want us to treat the leg pain before they even let us address the back pain. So in terms of our diagnostics and our tools, if there's true axial pain or back pain, we want to be able to address that as a separate problem.
So the back pain would be like sometimes on one side, in the muscles going down to the butt cheek. That's what we're describing as back pain, right?
Yes, sir.
And then the facet joints are in the back. So what I do is I ask patients to put weight on one side and lean back. And if their pain gets really bad on that, then I'm like, maybe it's the facet joint. And that's when I need my pain colleagues to help me out with this because I just want proof. And one way to do it is to do a targeted injection into the facet joint. And if you have an anesthetic, it will numb up that facet joint like at the dentist's office, and they should get better, right? And then the steroid will hopefully treat the inflammation. Now, sometimes the steroid is not enough. So we do a procedure, you do a procedure called an RFA, radio frequency ablation. What is that all about? Explain it to the patients so that they kind of have an idea of what it's about because I usually hear it's like, we're burning the nerve. That sounds bad.
It does sound bad. But when you think about nerves and electricity, wires, and you look at any wire, a coil wire that you would have, there's a sheath around that wire and the actual coil. When we're doing radio frequency ablation, burning the nerve, we're actually adding heat on top of this nerve that talks to the joint, and we're essentially melting the sheath around it. When you do that, the nerve is not able to send signals back up to the brain. So essentially, it's a semi-permanent way of reducing the signal that is sensing pain.
So it's not cutting that nerve or vaporizing it into oblivion.
And because our body is so amazing, this nerve regenerates. We have a natural healing process that takes time to the prevy of 8, 10, 12, 18 months for that nerve to then regenerate. And so that symptom can come back with a new healthy nerve, and it becomes a procedure that can be repeated at 9, 12, 18-month intervals.
So the goal is to provide like a year or so, 6 months to a year or even longer of pain relief, during which time you can get really healthy and fit, and hopefully you don't need another one afterwards.
And that is a very important piece of this. After a radiofrequency ablation, the goal is to reduce the spasms you get in your back, reduce the use of the anti-spastic medicines like Flexeril or cyclobenzaprine and baclofen, so that you can engage your core, engage your muscles, and retrain them.
Yeah, I have a lot of patients with facet pain, so I look at that a lot. From a patient's perspective, is it a lot different than an epidural steroid injection? And just from a logistical standpoint, what does the day look like from a patient's perspective?
Great question, Doc. It's very different than an epidural injection. We are essentially, like you mentioned, targeting a joint. So the same way you would get a knee injection or a shoulder injection, this facet joint is actually a synovial joint. It has two surfaces that interact. It creates fluid, or you can get cyst in that joint. And so
there's cartilage in there.
And cartilage. And when it comes to the facet joint, we usually block the nerve that talks to it, because many times in severe arthritis, there's no space. The joint is completely closed. I cannot put a needle in it. So we end up blocking the nerve. We call that the medial branch block. So if you stop the nerve supply to that joint or block it, there's two ways to do that as well. But with an anesthetic, you would get temporary block, which then again you get a pain diary for, and you report, yes, my pain was blocked for the next several hours.
So you want to do a block and confirm that that's the pain generator before you do an RFA.
Yes, and it's almost like you said, there's 5 different joints. We want to be as specific as possible and eliminate the source of pain, so we do it as a diagnostic. One caveat to this is that insurance does dictate how we get to RFA, and patients should know that this is a 3-step process. It's a frustrating journey for both of us, but when it comes to science and data, we have proven through our literature that if you get 80% relief on the first block diagnostic, and you get 80% relief on the confirmatory or the second block, then the radiofrequency ablation will work 80% of the time.
I can see why you won that award. That is, I don't think I knew those numbers. That's really, really helpful, because a lot of our decision making is predicting the outcome.
Yes.
Just to summarize from a patient's perspective, what are the key things you want them to remember about facet pain and radiofrequency ablation and things like that?
We are essentially going to a joint. We're not going anywhere near the epidural space. It's a diagnostic procedure, meaning that when you do the blocks, you should not expect weeks of relief. And that's one of the biggest misconceptions. Doc, it didn't work. I'm back in your office. But the most important thing is what you document on your pain diary.
The diagnostic part.
The diagnostic part, because it literally, an anesthetic that you would use is bupivacaine or Marcaine, and that will only, like half-life of that is 4 to 8 hours. So we're really just looking for the next several hours after injection. If you were able to do activities that you wanted to enjoy without pain, that is, again, at 80% relief, will give us enough data to move forward down this pathway.
Of the radiofrequency.
Of the radiofrequency. And the radiofrequency is the technology has been around for several decades now. And all the papers and literature suggest that when we have a probe that we put down, again, we're using the same type of needle, but instead of putting medicine, we're adding heat. The studies suggest that if you add enough heat, you will create a circular lesion around the tip of the probe, and that heat will then eliminate that the wrap around the wire. And if you can melt it, then you can decrease the signal to the brain.
All this through a little needle poke.
Just a needle poke, yes.
That is awesome. Thank you very much.